Well, good evening, everyone, and welcome to our webinar this evening, brought to you by Breast Cancer Trials. I'm already seeing some people that I know there in the chat. Don't worry that we have anything unpleasant or difficult in store for you, Andrew Parsonson. But I happen to know that you've got an interest in this area, which is telehealth, particularly in relation to clinical trials, and so we might come to you for some comment later on about things that you've been reading about and learning about. With me today is Renee Lim from the Handmclean Centre, and I'll tell you a bit more about her in a moment. But what we're going to do is we're going to focus our conversation tonight about telehealth on a particular clinical trial that Breast Cancer Trials is about to open in collaboration with the Canadian trials group called FINA. And hopefully some of you are going to be running that at your sites, and others of you will be using telehealth in particular trials that are already running. We had a conversation today at our site about the fact that in the future we probably need to build an ability to use telehealth into all of our clinical trials right from the beginning. So this is a good opportunity to hone up your skills in how to make that work well for yourself and for patients, and then we'll get to practice those skills. Our other participant tonight is one of the Handmclean Centre professional actresses, Margie Bell, and she'll be joining us in character later on in the session as a patient suitable for considering the FINA trial. Perhaps it would be appropriate for her circumstances. So you'll get a chance to meet her in the second half. And greetings also to Andrew Redfern, who's the Australian PI, and he's going to help us with our role play, but also with any specific questions that you might have about the trial itself. So how did we get into this area of teaching about communication skills by telehealth? Well, it kind of came because it had to. And we are aware, of course, that we'll just go to the next slide. Thanks, Renee. That we, over the last 18 months, have learned that there are strengths to the use of telehealth for our advanced breast cancer patients. But there are also some limitations, particularly as we were thrust into it very quickly without really a chance to prepare. And COVID really was a forcing function as far as I could see. Video was already being used in Australia for oncology consultations, but this was nearly always in regional and rural settings, and mainly around specialist services. So cancer genetics, psychiatry would be some examples where this was already working quite successfully. A number of rural clinicians were also using it to link into specialised MDTs for things like neuroendocrine tumours, although many of them described the tech as extremely clunky. And it was also being used in some clinical trials. So you would probably be aware of Sabe Sabasan, who has been running a teletrials project through COSA, and also some adjuvant studies, the Monarch E study, for instance, in breast cancer adjuvant treatment. We recruited very quickly in Australia, and one of the reasons this was possible was that telehealth was included, and so shutdown didn't have to happen here because of COVID. Now, one of the barriers to this was that in the past, the patient and the doctor needed to be at least 50 kilometres apart to trigger a Medicare item number for telehealth. And in fact, these item numbers were quite generous because they included some understanding of the fact that additional technology was used, particularly back in the day when you might have been paying a lot for your broadband. Well, why did it change? You have all lived through it. There was a sudden need to reduce footfall in oncology clinics, and in metropolitan areas, this was even more important. So some of our patients live an hour's drive away, even if they're not 50 kilometres away. Mostly were happy to use the phone if they already knew the doctor. And the video systems took quite some time to build up. So early work that we did was with palliative care physicians, for instance, who were using this in the community as a way of avoiding the need to travel around town. And the systems to share images and blood results, for instance, also took a much longer time to become flexible. BCNA did a survey of members towards the end of 2020 about their experiences of the pandemic, and one of the issues they asked specific questions about was telehealth. And women perceived that there were many advantages. They were able to continue their care with their usual team. They were able to make sure scripts and tests were on time, and reduce travel, cost, and parking, of course, always a sore point for patients with cancer. They could avoid taking a half a day or a day off work, and they felt safer at home in many instances, particularly if there were large numbers of COVID patients in the particular hospital where they were needing to attend. Some of them loved the ability to be able to link in their family members more easily, even if they were interstate or at work, and potentially access to clinical trials came up as one of the things that could well have been an advantage. Sadly, though, there were some problems, and these reflected the clunky sort of uptake. We heard stories of patients being asked to take off their clothes, for instance, to show radiation burns in open plan offices where there was a clinician talking to them, but people walking past in the background. Lots of frustration with technology that didn't work. The confidence and reassurance that patients have from having a very thorough physical examination by their oncology team was lost. And of course, prescriptions and tests had to be sent out by mail, which again was slow rather than taking things home. And some of the patients said, well, look, you know, it's difficult enough talking about sensitive subjects with your oncology team, let alone doing that over the phone or over Zoom. And some of them said, rather than wanting their family members involved, it was actually hard to avoid their family members, and they were busy hiding in a car or somewhere to get away from being overheard. And of course, oncologists didn't find it plain sailing either. They also reflected the privacy concerns, having been tossed out of their clinic rooms into open plan offices. Again, technology and getting through hospital firewalls was a problem initially. Again, not being able to do thorough physical exams, and lots of extra work for the staff, having to send prescriptions and blood test forms, etc., rather than being able to do that along with the billing while the patient was there. They too found it hard to be as sensitive over the Zoom, difficulty reading body language if the setup of the equipment wasn't good. And something that Renee has been looking at in particular, difficulties with expressing empathy and Zoom fatigue. And people would say to us, you know, I've only done 10 consultations today and I feel like I've run a marathon. Why am I so exhausted? And one of the theories behind this is that we have to use so much more of our brain to be able to read signals of empathy and whether it's working over video compared to using all of the signals we would have in the room. So our brains are tired. And of course, the digital divide meant that those who have and the have-nots were still in trouble, and those underserved populations were still not being reached. So, ta-da, to the rescue with Handmclean Centre. So our first calls were actually from palliative care, from McGrath nurses, from oncologists, and from other clinicians saying, you know, we need some help. Well, why are we placed to help? I know a bit about oncology, and Stuart Dunn knows a bit about psychology and the teaching of communication. But Renee Lim, a professional actor as well as a doctor and a director, has those experiences she can bring to bear from her work on film and television. And we were able to adapt many of the programs that we would ordinarily have run face-to-face communication over a Zoom platform. And you'll see here a number of people. Here's one of our actors in role, ready to go with a Zoom delivered workshop. People able to interact with the actor to deal with whatever subject it was of relevance, but to learn some telehealth skills along the way. So I'm going to hand over to Renee at this stage. She'll take you through some of what we've learnt in the last 12 months about how to make these things work better for us. And then I'll come back to you to talk a little bit more about the trial. Over to you, Renee.
Thank you very much, Fran. So hi, everybody. I obviously don't know all of you like I imagine Fran probably kind of does. But my background in medicine, I suppose, as a locum doctor, I do work in palliative care as well as geriatrics and emergency. I happen to, as Fran mentioned, be a professional actor. I'm presently in a hotel room in a country town shooting on a set, which is very secret. And I also have a background in education and designing education. And so all of those skills, I suppose, have allowed me to be particularly useful during COVID. If nothing else, I'm very comfortable in front of my computer staring back at me. And you may have noticed I seem to be looking at you, and that's because I'm staring straight down the barrel of the little dot that is next to my camera. So these are the kinds of things, I suppose, that when Fran and Stuart and I spoke about how we could help the health profession during COVID in particular, I was able to bring to bear some of these skill sets. And what we have found in the over probably 20 sessions that we have now run in telehealth internationally, that the skills that we're going to talk about are very easily transferable. They are also very easy to pick up. And even if you only change 2 or 3 things, I think you'll find that it makes a really big difference, both for the patient's experience, but also for you as well. And to clarify, telehealth for us does mean video conferencing, but some of these skills are transferable back to the phone. So I'm about to run through a whole heap of different ways that I guess we've learned to think about our clinic room when our clinic room is the online video conferencing space. If you can, I'd love you to be able to keep your little chat box open. And if as I'm talking anything comes to mind, just throw it into the chat so we can keep track of your questions. And I can come back to them at the end, either respond to them at the time, or if not, I can always come and speak to you afterwards or can pass on the information to you as a group after the event. So please don't think any question is stupid. Feel free to throw anything into the chat and we will come and deal with it later. So I suppose I want to start in the foundations of medicine, and nothing really changes. One of the things I think a lot of people found is they went into a Zoom or a video conferencing space and convinced themselves that they couldn't have the conversations they were used to having. Also, perhaps that they didn't need to think about those conversations the same way. But the reality is both that, number one, these are still really important conversations. And I think we've all seen we have had to deal with bad news at various times, and it wasn't in an optimal condition like it would be on video conferencing or Zoom. But the second part is you as a clinician, just like you have learned in your face-to-face interactions, have a lot of potential ways that you can improve the conversation for the patient. And if we think about the way we communicate as a therapeutic intervention, which I definitely do, and I'd like to think that most people in this room would as well, I think it's really important to own the responsibility of making sure that we do everything we can. And part of that comes back to the very old model of spikes. I can call it old now, I think. I can't believe it's 21 years old. And a model that has been around for a very long time and has been integrated into our communications training. It's been integrated into thinking about breaking bad news. It's been integrated into the core of oncology and palliative care teaching and work. So things like your setting, the space that you are in, and we'll talk a lot about that. The perception, how people are interpreting the fact that we're on Zoom. And that includes you as much as the patient. The number of clinicians that I have spoken to and that Fran and I have seen who have said, oh, well, yeah, I can't really do anything about that because I'm on a video conference. So our own perceptions as much as our patients. The invitation, the things that you need to kind of, I suppose, receive permission to do in a video conferencing setting almost become a little bit more obvious, but also a little bit more important. The knowledge that we share and the ways that we can share that, and some of the opportunities that video conferencing can provide that actually a face-to-face conversation is less likely to. The empathy piece, which Fran referred to quite a few times, is a really big one, and there are some simple things that we can do. And the final part, the summary and the stepping forward. And as we start to open up and we have more vaccination, you know, hopefully the stepping forward becomes a combination of face-to-face when it's important and when we'd like to, but also improving our ability to use telehealth to improve the ways that our patients can access healthcare. So when we think about the setting, and again, I'm assuming that we'll be sharing all these slides with you. Please don't feel like you need to write things down, but throw things into the chat if any questions come up. It's really important to think about the times when it is good to use video conferencing or a phone. So first, consultations are not generally recommended because obviously getting to know somebody and making them feel more at home and trusting of you is incredibly important and difficult to do online, but not impossible. Cognitive impairment can make things very frustrating and hard in the setting of a video conference, and that can include everything from which button to press through to things moving around on the screen or changing shape or size. A thing that needs a clinical examination, again, very difficult, and as Fran flagged, in particular in relation to privacy, even just to visualize somebody's body and their personal kind of space, you know, not to mention being able to physically lay hands on that person. Also things like language barriers. So language barriers become difficult, but interestingly, in fact, using an interpreter in an online space can actually be much more valuable than trying to use them over the phone. Drug and alcohol use disorders and things that are related probably more to, I suppose, behaviors can also be quite difficult to overcome in a conferencing space. And the obvious one, when somebody isn't comfortable with technology. I know Fran's put the word patient here, but I would argue, having worked with a lot of clinicians, I think we are as much to blame about not feeling comfortable with our technology as well. There's also your physical setting. And, you know, if we were doing this in the way that Fran and I normally do, we'd have you in a normal meeting and we'd ask you all to turn your cameras on and we'd look at your backgrounds and think about whether it would be appropriate for the patient to see you in that space. But at 7 o'clock at night, I'm guessing many of you are probably dealing with families and dinner and personal spaces, so we're not going to do that. But it's really important to think about the ways that your visual setting impacts on the interaction with the patient. And a part of that is because if you think about it really carefully, the patient has nowhere else to look except for where you put your camera. So Fran has done some great modeling for us here. I don't know how long this photo shoot took Fran, but we have 3 different examples. We have the very formal. I've never seen Fran look like this with any patient in my entire life. But the very formal, I'm wearing a badge, I'm wearing a white coat, I'm wearing a mask, and look, you can see my light and my X-ray box. So I'm definitely a doctor. When we're already in a visually distant setting, when we're already in a computer setting, this kind of need to be very formal is probably a little bit too much to deal with at the time. We also then have, I see Fran had help with her photo shoot. The second photo we've got here is Fran looking very, very friendly. And to be honest, I don't know that I would have a problem with this visual. However, it can sometimes be a little bit too much for a patient when they're dealing with their own issues to have to also interact with your setting in a significant way and try to make sense perhaps of the things in the background, or they may not feel as comfortable, you know, interacting with you when you do look like you might be on a weekend coffee break. The other part of this, which Fran is pointing out, is one of the things that our subconscious psyche is really good at is taking things we see and using our heuristics to interpret them a certain way. And for many of us, prior to using telehealth, this particular visual of somebody in a frame long ways like this is usually associated with FaceTime or a casual conversation on your phone, which would usually be to family or friends, and can subconsciously make you feel less like this is an important and serious conversation. The third one here is the carefully placed person in the background, which Fran has sort of pointed out, which makes everybody realize that no matter what you think you're doing because you're talking to your computer in this little private space. In fact, those people back there can see the screen. And in Fran's case, she's wearing very clear headphones, but maybe as well, in fact, those people out there might be able to hear what the patient is saying. The next step that's really useful to think about is your position. Now, most people, when they talk in a video conference, talk to their computer. So if my computer was sitting on my table, this is how I talk to my computer. This is my computer in the same spot. This is how I normally sit at my computer. And this is what you see. One of the issues with that is in the real world, when we talk to patients, we very rarely sit over them so that we are looking down at them and then stare at around about their chin. So the visual of watching me do this while I talk to my computer is, again, consciously and subconsciously quite disconcerting. So one of the simple tricks you can do, especially if you're using a computer that has a mobile camera, i.e. a laptop with a movable screen or a camera that you can move, is to put the camera flat. So basically have the camera almost looking at you the way the person's eyes would. So that's the first thing. The second thing is being able to get your camera to the same level as where your patient's eyes might be. Now, I'm not quite in that position today because I'm in a hotel room, but that would be something like this. And I don't know if you can see the difference, even just by moving that camera just a little bit. It makes me look a lot more normal. And the third part of that as well is giving yourself a little bit of distance between you and the camera. So in the picture you can see of me here, I'm actually giving myself about an arm's length. And the reason I can do that is it actually allows me to move my hands around. It allows me to talk to you. And visually, I start to look more like I normally would if I was in a room talking to you on the other side of a desk, or perhaps not even. There is the issue of the background. The background we talked about a little bit before. The two key things I suppose to keep in mind is what is actually in your background. So just to be able to have a look at it and to be conscious that the person you are talking to will be staring at this background the entire time. The second thing here is around virtual backgrounds. And again, virtual backgrounds are very popular. Just important to work out if you think that this will help the person you're talking to feel more comfortable talking to you, or may in fact be distracting or confusing. The third part about a virtual background, which we might see later on, is that they tend to move. So there's that really weird flickering that goes on around somebody when the computer can't quite differentiate you from the rest of your environment, and your virtual background starts to get a bit patchy. And that can be incredibly disconcerting and quite distracting, especially for a patient. This is a sort of very smart idea that Fran had. I don't know, Fran, if you want to talk to your space that's in this photo here.
What I did in this situation was that instead of sitting in my chair, I actually sat in the patient's chair, and I thought about what do I look like from where they sit. And looking from their eye level, they can see out the window. There's my famous crystal ball, the subject of another talk. And that's what they would see behind me. So I actually just sat in the patient's chair, took a photograph of what they would normally see, and then I can use this background even if I'm at home doing my telehealth consultations, rather than having my home background, which is what you can see here with the kettle and the, you know, looks like a kitchen. They can actually feel confident that it's like being in the room with me. And this is, Renee would tell you, a mid shot, so it's not the ultra close up that they would see if they were doing that. It's a little too intimate, and gives them a chance to actually feel more comfortable, I think.
Yeah, definitely. And it is that sort of perspective size what Fran's referring to, is when she puts this photo around her as a visual, it does look like she's sitting in her office, as opposed to going in too close and then having some weird flower sticking out of the side of your head. So I don't know if Fran is secretly trying to put it on in the background. We might see her room suddenly appear. The other thing that is really important to be conscious of is lighting. Now, this can start to feel a little bit vain and uncomfortable. It is something that we do. Oh, there we go. So Fran's just popped her background on as if she's in her office. And so as you can see, it does actually start to feel like you're talking to her, and that's her window behind her. which, you know, would make most patients, especially if they've met Fran before in her office, feel almost like they're just having a normal conversation. You do happen to have a very nice view, by the way, Fran, so that does help.
Probably nicer than some other oncology unit. There you go. It is a little boutique.
So back to lighting. So one of the things we think about in terms of lighting is not that you're trying to look pretty, but as Fran flagged, one of the main issues with what we call Zoom fatigue is the sense that we are doing so much work to do what we would normally do very easily. And one of the things that we normally do, and that would be the case, I imagine, for everyone in this group, is you watch somebody and you see their eyes flicker and you notice how their hands move and if they sort of change their position, and you can pick up on all of those details. And similarly, when you are trying to interact with them and express your own emotional space, or you want to show empathy or care, you will do little subtle things that will also allow them to read those behaviors off you. One of the problems with dim lighting is all of a sudden, a number of the things that we use to cue ourselves and others to understand our nonverbal behaviors disappear. That can be the case for all sorts of reasons, but lighting in particular is a very simple one to fix. Being able to increase the lighting in front of you, and preferably slightly to one side, will actually allow your face to be the most visible, the most readable, and actually will improve the chances of your patient being able to read and understand both what you're not saying, but also, to be honest, also to read your mouth, which we know is something that has been quite difficult in COVID. And we've discovered that a lot of people do quite a bit of lip reading to make sense of what's going on. Fran's chosen some other really great examples here where things like putting big lights behind you can actually make you darker and make you more blurry because the camera that you're dealing with is trying so hard to just work out what to do with so much light. We then get into something like sound. And again, I know there's a lot of stuff we're talking about today, but any one of these things is still very helpful, even if you just pick up one that you want to change. And sound might be the one that is the most interesting or the easiest. So we all have our preferred set of headphones for listening to music or to do our other work. When it comes to video conferencing for the purposes of telehealth, we actually often have multiple things to consider. And in this case, Fran is wearing her noise cancelling headphones. She then wears one with voice capture, so the microphone that comes out. And then in this third version here, she has tiny little earbuds. And depending on what your priority is, you might need to choose between the three. So the noise cancelling headphones mean you can hear really well, but they also will have a microphone sitting on the end of your ear sort of pod, which will also mean though that that microphone will pick up sound from anywhere. So it's going to be much less able to capture your voice if you're in a noisy environment. They also do make it very clear that it looks like you're listening a little bit like a DJ, which for some especially older patients might feel quite uncomfortable. The voice capture option is great if you want to be heard, but it does make you look a bit like a telephonist. And again, we have had feedback that people feel like it's a bit weird and it makes them feel like they're not in a real conversation with you. The third version, the unobtrusive ones, can be really useful because it allows you to look as normal as possible. However, sometimes, you will find that you won't be able to hear things as clearly. And while you don't want to have to be jumping around changing your headphones in a session, it can be useful to have a think about these things beforehand in the context of your larger environment as well. The one thing to really keep in mind, though, is we always recommend using headphones. The reason why that happens is because if you use your computer system, while it may sound great to you and you think there's no problem, every time you touch your computer or you tap on the keyboard, you actually can transfer those sounds through to the other people. We also have the idea of a patient checklist. Fran said to me that most of you guys would be very good at checklists. I think the only thing that we really want to mention here is one thing that can be really helpful to keep a video conferencing conversation on track. And one of the benefits perhaps is to be able to get the checklist out beforehand. That allows both parties in different spaces to keep track of the conversation and to know what's meant to be talked about, so that some of that stuff that we lose in terms of being in the same room and being able to keep a flow can be managed by both parties, not just by you. which allows, the patient as well sometimes to feel a little bit more empowered when they may be feeling quite uncomfortable. We need to consider both the checklist of what happens in the conversation, but also then kind of allowing us to develop a checklist for how we deal with things after we end this call, which can become even more important when somebody already feels so disconnected because they're not even coming in to see you in the clinic. So now we move into some things that are a little bit more unusual. And these are things that probably come from a combination of behavioral psychology, film work, as well as, I suppose, performance and acting. And one of the things that is actually an incredibly powerful tool in a video conferencing space is to acknowledge what is happening in the other person's room. As soon as you point out somebody else's painting or perhaps their pet that has walked into the space, if you acknowledge anyone else that's in your space or anything else that you can hear, it automatically creates a better connection between you and that person. And I'll be honest, actually, a lot of people do find that when they mention it, they realize that they can now see a window into their patient's space, which is something they've never really been able to do before. And it can become a really great rapport building tool. Always important to know that one person can speak at a time in most video conferencing tools, though that has been improving. There's also, I suppose, that component of, well, what else can we offer in the video conference? And again, very specifically in some ways, while we can still show scans and blood tests and diagrams, it may feel a bit harder. The flip side that I will mention is the knowledge, the recording perhaps of this interaction could actually be used by yourself to, where appropriate, share with a colleague, and or by the patient to be able to share with their family members in an asynchronous fashion. And these kinds of things, which seem weird face-to-face, when someone puts a phone out and says, can I record the conversation, are probably more uncomfortable. In these environments, recording and the use of sharing of recordings is actually much more comfortable and more normal. So that is something to consider, obviously with the associated securities required for data. So what do we do about the big emotion question? Well, I would argue for first, if you can find ways to create environments where both you and your patient are sitting like me, you're going to pick up on a lot more nonverbals than you would if I was talking to you like this. So when I'm down here, I can be flailing my arms around, I can be fidgeting all I like, and pretty much all you'll see is my face. The ability to either yourself, so primarily you being able to lean forward and lean back and be able to engage in more nonverbal behaviors that other people can see, versus if you can't actually visualize any of those things, can make a huge difference. But what actually makes it the extra step of importance is when you see any nonverbals, to acknowledge that they're happening. We tend to start to discount our emotions and our nonverbals and the things that we don't share with our voice because we're on a video conference. At one point, I have seen somebody who was sitting there like this, talking to the person, and they would never have done that face-to-face, but because they were on a computer, they just kind of forgot that it mattered because they were just thinking about what they were saying. And it wasn't until we pointed that out that the other person could visualize this the entire time. They were like, oh my gosh, I would never have done that. So we tend to numb ourselves a little bit to our nonverbals when we're on a video conference. And it's really important to both recognize they're still there, but also to be able to acknowledge them, to point them out, to recognize and see them and ask questions about why that person might be doing that. The other thing about, I suppose, this space is this silent witness, the pet at home, which is quite interesting. I don't know how many of you have a pet at home or a family member, but it is very, very, what's the word? It can be very reassuring, I find, to know that they do have someone on the other side. And that pet or that family member can actually become incredibly powerful in engaging you in the empathic process of supporting that patient that you're talking to. So don't ever discount having the silent witness in the room. There are some very specific tools you can use. So obviously facial expressions is the one we know well. And to do that, you'd need good lighting and you'd need to be able to probably, move your head. If you're this close, whatever facial expression I have is probably a little bit too intense. So, it almost becomes a bit too much. But from back here, my facial expressions actually start to matter. Similarly, there's a tool called mirroring. So if I'm talking to you and I wish that I could actually reach out and touch your shoulder, this looks weird, but something like this actually can create that sense in the person who's watching that there is a connection and that there is a sense of touch. Similarly, being able to hold your hands or being able to hold, like sort of grasp your hands together can also do a similar thing. So both of those are very useful tools in being able to replace certain behaviors that you can't replace otherwise. Leaning in and out, again, is also one that really indicates non-verbally that you're more connected. It is very hard to do when you're talking to your computer. It's much easier to do when your computer is the same distance as the person that you would be interacting with. Eye contact is a great one. And I mean, a lot of these photos are actually related to glasses. I'm very fortunately, I don't quite know why my glasses don't seem to reflect the light, but a lot of people's do, and you end up with a combination of, Fran, I don't know what you call them. I can't remember. One's the night walker, I think. And the other one.
So the blue eyes are the White Walkers from Game of Thrones who come to steal your soul. The black ones are the Italian master who, he's got a beautiful photograph behind him, and it could be anyone, but it actually is a famous oncologist. And of course, Alan Coates, many of you would know, who possibly was on his iPhone, but has an ability when he's really, really listening to do that with his eyes shut. And I know some people do that. They do that, I'm really listening to you, as if I've got to shut out other signals. It often looks like he's about to have a cardiac arrest. And given that he has, as people will know, had several, it's quite worrying. So please, if you are someone who closes your eyes all the time, be very careful. The blue one is from the television, and this is someone who I think was reflecting the blue of their computer screen on their non-reflective coating on the glasses.
Very common. And again, there are a few things you can do around angling your screen if you need to, and actually putting your screen upright like this actually helps to get rid of some of that glare. So it can be a really useful tool to make your screen more flat. The other thing that I suppose, which you may or may not have noticed, I said I'd mentioned before, I'm very used to talking into a hole. As an actor, that's often what we do. And as a presenter, it's kind of the camera is my best friend. So you may not have consciously realized this, but I actually am making eye contact with you. But when most of us are talking in video conferencing, we're much more likely to be talking to the image on our screen, which would be down about here. Now, that's very normal. And to pick up cues, you need to be looking at the person. So I don't expect you to look up into the camera all the time. But it can be incredibly powerful when you're talking to the person, to when something really important or very personal or meaningful needs to be said, to look up to where your camera is and make direct eye contact, because that can make a huge difference. So the final part, I suppose, is thinking about that support and summary piece. And as I mentioned before, when we're already disconnected, we're already sitting on a video conference, we're already kind of like navigating a whole bunch of other things. The ability to know that there is a next step that is consistent between both parties is very, very helpful to keep that connection where we can. So in this case, and it's Mona, I believe, is that right, Fran? Is that what you're hinting at? That this is Mona sitting here in the photo. Being able to actually have either a person there who can support and provide that follow-up, or to be able to provide that information afterwards in documentation is incredibly helpful. And it's obviously very, very possible. There are tools that happen within the video conferencing tool itself that you could even share at the time. But utilizing technology to send an email afterwards or to follow up is also really, really important. And there's a whole bunch of things here some of which are quite general, but I think some of which, Fran, might be very, very cancer specific, which, you know, you should always be following up on at the end of a session. So we're going to pause there. And there weren't particularly anything in the chat that has popped in, but does anybody have any questions or thoughts about what we've just sort of gone through there? Anything that anybody would like to be able to kind of drop into the conversation at this point, or anything that you'd like me to clarify? This is the biggest difference we have, Fran, between using the meeting and the webinar.
So Mona was, we'll come to that in a second, Maria. Mona was complaining about costume today and that she hadn't had a chance to go to hair and makeup before I was photographing her. And costume is something that's important, isn't it? And makeup. Yeah.
And I think the costume part you referred to in the formality of the images. I suppose makeup is one of those things that's a bit complex. We're not asking you again to, I suppose, focus on trying to look pretty, but it's more about being able to identify our features. In most of these technical settings, we'll find that these cameras aren't, you know, HD. And so we lose a lot of the detail of our faces. And so things like makeup, jewelry, the types of clothing you wear help to just redefine those features to make them easier to read. And that would be why. The issues of
confidentiality with
Yeah.
recording.
So Maria, I mean, that's a very important one. And I do think there's a few things to keep in mind there. My understanding in most of New South Wales, at least, there are set up systems now whereby you can record conversations and they will automatically go to the cloud. Once in the cloud, and if they're stored in the cloud, then that is secure from the purposes of the organisation. Sharing that recording, I suppose, becomes very similar to a patient note or a printed document. And it really will depend on who you share that recording with. They generally would say that these recordings would be password protected, and then you can share them with the patient. If the patient chooses to pass that on to other people from their perspective, that would be appropriate. However, of course, you are now in the recording as well, and that is a separate conversation. What can be done as well is you can cut sections of a recording. I do know some people that have gone to that level where they've actually taken sort of parts of a recording and shared those parts of the recording to allow patients to be able to share information with other family members. So I hope that flags a few of the issues that come about with recording and sort of at least sends you in the right direction. So in particular, where is it stored? How is it shared, and is there a password protection, and what agreements are there between the two people that are involved in that conversation or more? Everybody has to give permission for that recording to be used.
Martin Tattersall did some work years ago with cassette tape recordings of consultations, and they found that it helped to improve recall of the key parts of the conversation. Some patients said, I use this in particular to share with my family, and other patients said, I just love his voice. It's so soothing. I could listen to it all day. So if you have a soothing voice, that could be good. Andy's made the comment that typing at the same time, particularly into a medical record, can be very distracting. Have you any suggestions, Renee, in that regard?
Yeah, so this is an interesting dynamic. Generally, what we would recommend is to have them on separate computers, because actually not only is typing disconcerting, but when you're typing, you tend to be looking off into the distance, and it starts to look like you're even quite distracted and not in the environment. So the things that I would say, first of all, is to acknowledge the environment. So tell people, I'm going to have to be typing a note while I'm talking to you, because again, they can't see the things they can normally see when you're in the room. So letting them know you're doing that is a good start. If possible, then if you're able to double screen or to have two devices, and maybe use your smart device, which is mentioned later, in the context of the conversation, and you have your computer separately, that allows you to change I suppose position so clearly that they know what you're doing. Even being able to see, so for example, if I was to pull back here, let's say that I was typing onto my iPad. So if I was here talking to you, and then all of a sudden I started doing this, it would just look a bit weird. But as soon as you can see me holding the iPad, if I've told you I'm typing and I just sort of am looking at you and typing at the same time, it becomes much more normal. So I think the things I would say 100% is where you can split your screens or your devices. Always acknowledge that you're going to be doing it in the space, and that's where having headphones instead of using your computer audio might help as well, because it will stop that tapping sound. And the third is, you know, if you are using a separate device and you can visualize that, it actually will just make things feel so much less incongruous.
So Andrew Parsonson has a question about who else might need to know this information that we're sharing tonight. And I think that's your randomised trial, isn't it, Andrew, for your PhD? So we can talk about that later.
We can. For what it's worth, Andrew, as I said, we've already done 20 of these sessions in different contexts. So people are very interested. Obviously, those who are probably in more urgent need have come to us first. But we have taken this locally and internationally, thanks to Fran. I'm sure if anyone who knows Fran knows that with her on board, it pretty much spreads like wildfire. But yes, absolutely. There are great ways to allow for training. This is more plenary based, but we do tend to like to work directly with people, so keeping smaller groups. But if you would like to talk to us separately, we're very, very happy to do that. And the final question here from Sean.
Yeah, different types of devices. I think a lot of the patients that I've observed have been using their iPads, some using phones and some using computers on desktops. So there's been quite a range. I was surprised with the older patients how many of them seem to use video to interact with their grandchildren. And somebody in the family, presumably the grandchild, has taught them how to use WhatsApp or one of the systems. So when you use the New South Wales Health one, which is called PECSIP, you get sent an invitation. With Zoom, you get sent an invitation. You do need a 14-year-old at the other end to help set that up. But I know some people will only want to use the phone, and if they know you well, that probably could work quite well. But I don't think we can really distribute the devices or force people into it if they're still really struggling with it 12 months on.
Yeah. The only thing I would add to that, Sean, I think as Fran is hinting at that, you know, usually somebody in the family will have some access to technology and or a carer. So what I would really encourage to try is asking them to give it a go at one point in a video conferencing environment, whether it be coming into the clinic and having a video conference with, say, somebody else in that space, or, you know, working with their families to try to access it. Very few people find once they're using it, if it works well and if the clinician is owning the space and using the space well, that they don't actually prefer it, and at which point there will often be options. In terms of, I suppose, specifically if they're phone-based and they're not using a video conferencing device, there are a few things that are still very important from what we've talked about. So one is sound, making sure that you are thinking about the sound context when you're talking on the phone, and, you know, not sort of, I suppose, forgetting that they can hear you a certain way. So if you're using headphones, for example, and you're typing in your computer, they'll be able to hear those sorts of things. Things like acknowledging what you're feeling. So being able to verbalize your emotions becomes incredibly important. Many of us use our faces and our lean to deal with that, but being able to say the words, I am actually very concerned right now from what I'm hearing from you, that kind of language becomes even more important. And the third one is probably the checklist or the documentation. The ability to share something beforehand with them, especially if they're just on the phone, will allow them to keep track of the conversation and feel like they're following it with you. So those three components are still very useful.
And a checklist is really an example of agenda setting, which was probably what we would have called it some years ago in conversation, but we've all learnt now, I think, that many patients come in already with a list of questions that they've put on their phone or they've written down in a book, and we've encouraged them to do that. In the trial camp context, we'd always encourage them to do that. So it doesn't have to be on the screen. It could just be something that they've got on paper that helps to guide them through the consultation, so they don't forget things and then ring back and say, oh, I forgot to ask for a script.
The one thing I will sorry.
Drives your secretaries crazy.
But the one thing I will add for everybody, if you have the option to use a video conferencing platform and the internet is stable enough, I would recommend trying to use that even if you do it as a phone consultation. So having the video conferencing tool and just turning the camera off, and just, if people may say, oh, I don't like video, you say that's absolutely fine. You don't have to have your video and we'll use it like a phone. But the reason I say that is twofold. So the first one is it allows you to turn your video on if you need to share something or you would like them to see you, and they don't need to do it at their end. So it doesn't have to be mutual. And the second one is, for all that you may think, yes, this could be done on a phone, it may be that at some point during the conversation, something changes. And the value of you being able to put yourself in the room, so to speak, can become incredibly important. So where possible, even if someone says, look, I don't really need to do a video conference, you might still want to use the platform. And that would just allow you the option of being able to swap into a video conversation if it ends up being of value. Okay.
I've had one quite scary experience, which was doing a second opinion post consultation with somebody who'd completed their treatment elsewhere in a rural area. And to me, it looked like they'd had pretty much all the standard things. And I thought, well, I'm not sure that there's going to be too much in this. Sure, let's do that as a Zoom meeting, because they're about 6 hours drive away. And about halfway through, the patient who was there with her husband, who was a dentist, and clearly really hungry for technical information and really wanting to know detail, said, is there anything about her treatment that you would have done differently if she had come to you in the first place? And without thinking about it too much, I said, oh, yes, we'd have given the chemo before surgery because we do neoadjuvant and we have trials and blah, blah, blah. And she burst into tears and disappeared off the screen. And I thought, what do I do now? But he hopped onto the screen and said, I probably shouldn't have said that. And I went, you go sort it out and call me back. Anyway, I eventually got to meet them in person, and I said to her, look, I was really still learning about video consultations at the time, and I'm really sorry that you were very upset. I was probably a little bit too honest, not honest, but blunt. And she said, yeah, he was covered in bruises afterwards, but it was the right question to ask, and she's now sorted out. But it made me realise how important having that other person there could be if there's an emotional reaction you don't expect. I was quite freaked out by it for some time.
All right, so we'll move on now to the role play. And I'm just, I suppose, acknowledging, please feel free to keep throwing questions in as they come to you. Again, I can either answer them or we can just follow up with that afterwards.
That's great. So thinking about how we might adapt telehealth to clinical trials, we've chosen the FINA trial because it's ready to go and has telehealth written into it, which is great. It's led me to go back to the COSA Teletrials project and to look at these national standard operating procedures, which have recently been published, and for the first time with GCP, they include teletrials at every step that you would go through the GCP operating procedures. So I've just pulled out a couple of bits here. One is that the site setup has to include your decision as to whether you'll use telehealth at the outset, ideally. Now, going forward, that's easy. We're on catch-up mode, of course, for trials that are already underway. The consent can be done in person, as we've always done it, but you can also consent by telehealth, email, or phone where that's appropriate for the particular trial, and there are different operating procedures for those, but they're all considered to be acceptable now. But one of the things they talk about is that you need to identify the participants at each visit. So if I've never met you before, you don't know that I'm Fran Boyle, and I don't know that you're who you say you are as a patient consenting to a clinical trial. And if you don't tell me that there's somebody else in the room who's coercing you into doing something you don't want to do, that's something I would have picked up very easily in the room if you were there with a family member, but might be quite a bit harder. So whether that's having the uniform Mona, whether it's the name tag that you at least show kind of for fun, or some way of making sure that you've identified that person. When you do the visit record, and we have templates for most of our visit records, you need to document that telehealth was used. So be that a paper template or an electronic medical record. The protocol name, the consultation notes and the follow-up are exactly what you would do in normal circumstances. Now, most oncologists, I think, are quite used to this now, because for charging anybody through Medicare, you've got to document that it was telehealth and the patient consented to that, and the reason. And in this case, it would be COVID or a trial. But it is also the case that in any source documentation that you might have as a trial visit done by a nurse or a trial coordinator, again, documenting which medium was used is important. So here's the finer trial schema, and I'm not going to go into huge detail about this because I think you're probably mostly very aware of it. But we're talking here about a patient population of women with metastatic breast cancer who have progressed, or whose cancer has progressed on first-line CDK inhibitor along with an aromatase inhibitor. And there are now a lot of these women who've gone well for the last 2, 3, 4 years and who are now moving into that second-line setting. It's a very active area of clinical trials, and this is just one. They will be randomly allocated to receive ipatasertib, which is an AKT pathway inhibitor, along with their fulvestrant, so the intramuscular hormone blocking drug that since April has been on the PBS for this setting, once every 28 days, compared to patients who will receive the same hormone blocker and a placebo. So the oral placebo will be given along with the fulvestrant. So another way of saying that is to say everybody gets the same hormone blocker, the fulvestrant, the main side effect of which is a pain in the bum, literally, because it's an unpleasant intramuscular injection, but is otherwise very well tolerated. And for many patients who've been on CDK inhibitors, it's actually better tolerated. And half of the people will get the active add-on ingredient ipatasertib. Half of the people will get a placebo. And in fact, most of the trials, apart from the CAPTURE trial, which are being designed in this second-line setting, are very, very similar to this. You add something else to the fulvestrant. They'll be continued on treatment until disease progression or toxicity or withdrawal of consent, and then have their end of treatment. So progression-free survival is what we're mostly looking at, but overall survival is also being captured in these studies because we're starting to see improvements in overall survival with both first and second line endocrine agents in the metastatic setting, which is new and fabulous. So you'll meet lots of people like Rebecca Thompson. Beck will be joining us shortly, and she's 65. This is a slightly old photograph of her from when she worked as a nurse, looking very glamorous there. These days, she's living on a farm outside Warwick, which is in southeast Queensland, on the Darling Downs, and her treatment is given in Toowoomba. So it's about a 3-hour round trip for her to have treatment. In the past, she's worked as a nurse in various contexts and has moved back to the farm a couple of years ago, where she lives with her family and cares for her elderly mother. This was after her dad died. But she loves the farm. Riding's her passion and what she does for relaxation, and she has a number of very mild, well-controlled comorbidities. So her cancer journey is one that we're seeing as being fairly typical. She had a screen-detected breast cancer in 2014, surgery, radiotherapy, chemotherapy, and an aromatase inhibitor at that stage, which she did not tolerate well. She was going through menopause herself at the time, and it was not a pretty sight with her arthritis. But she's tolerated tamoxifen quite well and managed to get to 5 years on her endocrine therapy. And just when she thought she would be getting off the tamoxifen, she started to develop some chest pain in her bones, thought to be related to a cough and a chest infection, but was found to have lung and bone metastases. So for 2 years, she's been on letrozole and ribociclib, and she's tolerated those well, which is interesting and something we see in people who sometimes have had a rough time with an aromatase inhibitor when they were younger. And there is a little theory that CDK inhibitors might help some of those menopausal symptoms of aromatase inhibitors to be less severe. She's also had denosumab for her bone metastases, and she tends to give that herself because she's able to give her own injections. Now, recently on one of her scans, which was done after she developed some increased pain in her back, she was found to have a new lesion in the 8th thoracic vertebrae, and the lung metastases have grown, and they're now measurable, a couple of centimetres in size. So she's had radiotherapy to the bone metastasis, which has worked really nicely, and she has options now for her next type of treatment. I mentioned before that fulvestrant would, since April this year, it's been properly funded and would be on its own a standard form of treatment. Chemotherapy could also be considered. She's really not had a lot of chemo in the past, and there are a number of agents that she would probably tolerate quite well. She hasn't had an anthracycline, for instance, and she could easily have capecitabine. So chemo would be an option, but also a clinical trial, and this has been mentioned to her as a possibility. Let's think a bit about her life and what's been happening in her non-cancer life and how the two of them intersect. So she's worked as a rural and regional nurse for many years, and when she initially had her cancer treatment, she went part-time and stopped for a while, but she did continue until 2018 when she went back to the farm. And it was not long after that that her cancer returned and has now returned again. And this is her with a couple of her favourite friends. In the meantime, her husband Steve has had prostate cancer, which was treated quite easily with just surgery, and her daughter Steph has had twins who are now 4. She lives in Ipswich, so about 4 hours away. And her son Simon, who lives with her on the farm, is planning his wedding next year. It was meant to be during 2019, but she was sick initially, and then COVID hit, and it's been delayed and delayed, but finally there is a date for next year. So the FINA trial could actually be suitable for her. Fulvestrant would be a standard of care, and this is important to consider before talking about any clinical trial. If the patient has a significant reason why they would reject the standard treatment arm, there's no point realistically in going ahead and talking about the trial. So if she said, "No, I don't want my bum to hurt when I like horse riding, and I don't want to travel to have my injections," then you can probably save your breath to a large extent. On the other hand, she may say, "I'm not ever having chemotherapy again." So she may be willing to make some concessions about those things. She doesn't have any significant other problems, no history of clotting, normal organ function. She's got the measurable disease now that she needs to have, good performance status, no contraindicated medications, no brain mets, and she's recovered from her radiotherapy. So She's been sent the consent form by email. She's also been sent a link to a video, and this is a little bit of a new thing for BCT, so we're going to show you in a moment a little piece of that video. She's coming online to discuss the trial, and she's going to, first of all, meet Dr. Redfern, who she doesn't know. But let's, Mitch, if you don't mind, just go to the video to start with.
It is important that you take as much time as you need to decide about taking part in this study. Talk to your family, whenua, friends, and or a family doctor about taking part. Feel free to ask any questions at any time. All research is voluntary. You don't have to take part if you don't want to. If you decide that this study is not right for you, you will continue to receive the best possible care for your breast cancer. If you do decide to take part in the study, you can leave at any time, and this will not affect your care in any way. Just let the study team know as soon as possible.
If you want to take part in the study, you will need to review the information about the study, meet to talk to the study team, and ask any questions you might have to make sure you understand what you are agreeing to do in the study. Sign the consent form, which will be available online or can be signed on a paper form.
Fulvestrant is commonly used to treat advanced or metastatic ER-positive HER2-negative breast cancer. We want to find out if the cancer will remain under control for longer in patients treated with a drug called ipatasertib with fulvestrant compared to with fulvestrant treatment on its own. Endocrine or hormone treatments with CDK4/6 inhibitors are effective in treating ER-positive HER2-negative breast cancers, but in advanced breast cancer, the cancer eventually grows or spreads despite the initial endocrine treatment. So other treatments are needed for these resistant cancers.
All living cells, including tumours, have functions that make them develop, grow, survive and die. The PI3K-AKT-mTOR pathway within cells is important for cell growth and survival, and it may cause some ER-positive cancers to become resistant to endocrine treatments.
All right. Fran, shall we ask Andrew to join us with his dog?
Yes, his beautiful dog. Where's the dog, Andrew?
The dog's done a runner, unfortunately. So,
I'm
a quick learner, but they're very hard to control. She'll probably be back, probably at exactly the wrong moment.
Yeah, look, what's her name?
Remy.
Remy, lovely. So we're
5
going
months
to
old.
get you to meet Beck. We're just really going to ask you to kick off the conversation. And I think here, let's think about your setup before we do that, Renee. Any suggestions that you could make for Andrew?
I think, Andrew, we had a chat earlier, didn't we, about sort of your situation. You were saying that you've got limited options as well.
Yeah. This is the least domestic option, I guess, as I'm at home at the moment.
Yeah. I suppose if you're in a workplace, there are certain things. Are there any things that you're kind of conscious of, I suppose, since I've kind of barraged you with all of those different things to think about, that you're conscious of now that you would be trying to work on?
Yeah, I mean, usually I do it from work. Often have a little bit of, I usually tidy the office. I have to say, I don't just go for it. I tidy the office before I embark on a video call, so that I'm pretending it's tidier than it normally is all the time, obviously. And I do have a microscope in my office. It's just in the background. It's got this like very mildly kind of intelligent look to it. Obviously spurious, but it's and then a little bit of a stethoscope's usually good, but it's still a modestly soft thing other than that. Rather than being too clinical. So I do tidy up before I go onto a video call, certainly.
I think that counts.
Certainly my glasses are kind of shiny on the one side. And also the backdrop obviously being blurred is giving that slightly artificial green screen look of my head appearing. Makes me look like I'm even bolder than I actually am, which is unfortunate.
That's a good analysis, thank you. So I've also just run into the chat list, so it might help you a little bit as well, Andrew, though I'm sure you're already probably thinking of a million things. What are the questions or issues that need to be considered in Beck's case? And David has just mentioned, what is she seeking out of the treatment? What does success look like for her? So if the rest of you guys can start to drop some of those things in as Andrew starts, it might also help him to work out what things to pick up on.
And I noticed with your glasses, Andrew, that if you get a little tiny bit closer to the camera and look a little bit further down,
Oh yeah,
it disappears. And you might be able to achieve that anti-reflective effect by just shifting them on your nose a little bit.
I've got to still look at the camera, which is Thompson. Yeah, I do see what you mean. Yeah.
Yeah, it makes a difference, just the tilt of your head. And that tucked in chin is what the occupational therapists tell us we should be doing for our necks and backs anyway.
Oh, is that right? Don't know about that now.
Yeah, the chin tuck.
I'm just going to have some work done, come back, and then I'll tuck in my chin.
Yeah, too much Botox probably would not help Beck because of the, impact on being able to read people's faces. So other questions so we might think about other clinical trials. And in fact, one of the other clinical trials that might be an option for her is being run by BCT in some other centres in Australia, which is the CAPTURE trial. So the chemotherapy versus the PI3 kinase inhibitor with fulvestrant, and other clinical trials that are being run in other locations, which for her would probably be further away, with some of the novel SERDs, and they're being used in this same population, so oral treatment, which I think if they prove to be as effective as fulvestrant will make them attractive options because of not needing to have the injections. That's right, the aim of treatment, Maria. Cure, not cure. We're not really sure where her head's at. Extension of life. We don't know where our heads are at.
Shall we get started, Fran?
Let's get going.
All right, so Beck, do you want to turn your camera on? So Andrew, as we sort of flagged, this is basically the initiation of a conversation. We are assuming that Beck has spoken to her oncologist and has an understanding of standard treatment. So there isn't a need for you to sort of, I suppose, go right back to that sort of level. This is her first interaction, though. She has shown an interest in finding out more about the trial, so you haven't met before. Does that sound like enough to start with?
I think that's good to go, yeah. As well as the detail Fran has given as well.
Yes. And I suppose it's worth flagging for you that at any point in time, you're welcome to stop the conversation and we can just have a bit of chat about what's been happening. Similarly, at some point, Fran or I might stop the conversation as well and then just talk about what we've seen so far and get some feedback in the chat from the other people watching. Okay, thank you very much for giving this a go. Good luck.
There is also, I'll preface by saying there's the potential I may have to stop for a paroxysm of coughing as we have everything but COVID over in WA at the moment, unfortunately.
Yes, but it's not COVID, correct?
I've had swabs, apparently it's not, no.
Okay, all right. So what we'll
you
do
would have
is
seen it in the papers also, if it was.
Yeah. Okay, so let's time in now.
Okay. Hi, good afternoon, Beck.
Hi, how are you?
I'm hanging in there, thank you very much. My name's Andy Redfern, as I'm sure you've gathered, and I'm one of the breast cancer specialists here in Toowoomba. And as part of this, I'm also running the FINA study I hear you've maybe interested in hearing a little bit more about and potentially taking part in.
Yeah, my oncologist mentioned it to me, and I did watch a video that talked about it. I haven't decided to do anything yet. I don't really know what I'm going to decide, but yeah, I have some questions that I would like to talk to somebody about, and my oncologist thought you would be the best person to speak to.
Would you like me to give you a sort of a summary of the trial before we start, or would you like to move straight into your questions?
I think I took notes while I was watching the videos, so I do have a pretty good understanding of what it is, and I do understand it a bit. I'm a nurse, just I don't know if you know that or not, so I have a little bit of understanding. But yeah, look, I think my question first is, and this might be a silly question, but I know that they have to do drug trials. I get that in medicine, but this trial with the injection, that by what I understand is already a treatment option without being in a trial. Yeah.
That's correct. Yes, exactly right.
So adding another drug is what this trial is about. So I don't quite get why there has to be a placebo arm, why the trial just isn't the injection plus that tablet, because there must be other people not on the trial that are just getting the injection that you can make that comparison. So I just want to, maybe I'm a bit of a skeptic being, a nurse and having all those reps come into theatres trying to sell us things, but yeah, so I just want to make sure I understand that and have a clear understanding.
Yeah, for sure. It's a great question, and it's certainly a question that's I guess we've evolved doing it this way over a number of years. We certainly in the past, drugs often came along that have been given to a group of people with a condition, and we've as treatments have become more complex, with especially breast cancer treatment, as you know, there are many options and elements as you go along through it. We've found that when we do it that way and we look at a series of people that have a treatment and we go back and compare it to people of old who are maybe what we call historical controls, we find that when we then go and do a trial, we don't get the same results. We find that when we just treat a group of people and compare to people who have been treated a good bit in the past, we don't get a reliable comparison. The reasons of that are manifold. For a start off, you've already had some treatments like your ribociclib and the anti-estrogen treatment, and you had the chemotherapy. If we went back and compared to people quite a long time ago who might have just got fulvestrant, they may not have had those treatments, and so they'd be in a different position.
Sorry, do you mind should I wave at you if I have a question? Is that, I don't want to interrupt you too much, but
no, that's just what wave is good.
Okay. That's what my children do when we're trying to, do the Zoom things with COVID. So I think you're trying to say is that you want everybody who's been through the same treatments already, like traveled the same journey, if you like, to be in the trial. So
exactly right. Yeah.
Okay.
And from the same place and have the same mix of ancestries and a similar mix of ages, and likely to get a similar mix of treatments in the future as well, because they'll be treated in the same centres. Yeah.
Okay.
So it's a true comparison of just adding this drug and changing nothing else. Whereas if we take people from older treatments and other centres, many other things may change, and that's probably why we find that we don't get a reliable comparison when we look at what we call these historical controls, comparing people in the past who just have fulvestrant.
Okay.
So we're just going to pause there for a second. And this is just the pausing thing that we do. I'll just take Beck off for a second. So Andrew, how are you finding that conversation so far?
It's good. It's a very detailed question. Nobody has ever asked me in 25 years of consenting for trials. People have said, if the early trials have shown it looks to be effective, why can't you just give it? And we say, well, and that's a slightly easier question. When you talk about historical controls, it's very complex as to why a group of people are treated historically with the control arm aren't as reliable a control as a randomized group. And so it's a little bit of a nitty-gritty question for sure. It's a good question.
Yeah. Does anybody have
it's a hard start for 10, I would say, though other people may say, oh, that was an easy question. The thing I was about to say as well is that it's, I can say to Beck, is also because of this more reliable results that got from these randomized trials that government who decide on taxpayer money insist on this kind of trial, both in Australia and internationally, in order to agree to fund these drugs for everybody going forward. So if we don't do this trial, then nobody after the study would be allowed to have it or will get it funded.
Yeah, right. If people want to throw some comments into the chat about that part of the conversation, just sort of things you noticed, phrases Andrew might have used, or kind of how you might have approached the same question. I must admit, yeah, it was quite full on. Before we jump into the content, I guess I just want to focus a little bit on the telehealth. There was one thing in that particular section that was a useful reminder for us. Was there anything you thought about, Andrew, just more in terms of the video conferencing part?
Not particularly, no.
So one of the things we often talk about are ground rules. It's funny when we're in hospitals, we kind of we have established ground rules, we know what they are. You know, she did the wave thing. She was like, oh, am I allowed to interrupt and do I wave? And it can be really useful just to make that really clear up front to whoever you're talking to say, look, these are the rules. So, you know, in this case, I've said, chuck things into the chat, guys, like that's where we'll talk. But being able to give the patients a clear way to talk back to you, because many of them will feel for lots of reasons they shouldn't interrupt and they shouldn't get in the way. And if they've had any experience of video conferencing, they know that if they interrupt, it'll break the flow. So they can often become even more passive and sort of subdued than normal. So just really useful to bring that up.
This particular scenario is slightly more unusual. I've really talked about a trial right from the beginning where people have not had the information beforehand. So I would normally go through give them the nuts and bolts of the trial, and I would say any questions, any stage asked, but because we went straight into her questions, it didn't seem quite necessary to set that ground rule as we were sort of into the middle of a standard conversation. But certainly I didn't therefore think to invite her to interrupt if she wanted to know anything. That's correct.
Yeah, no, and it's just because it's the video conferencing space. I don't feel like she'd have trouble interrupting you normally, but it's because it's, I think, on a video conference. So there's a couple of comments here. Fran, did you want to pick up on those?
I think bias, which David Porter has mentioned, does come into this discussion about why randomised trials. And I think all of us need to have a couple of little different spiels that we like, different ways of describing randomisation and why it's important, why a control group, why a placebo, those sorts of things. And previous work that we've done suggests that there are some better ways to do that. But Leslie Gillum has also worried about your health, Andy, and that you're hanging in there. She's kind of glad you haven't got metastatic breast cancer, and she's a little bit worried from the sound of things that that may not have landed so well with Beck. Now, because this is a workshop and not real life, we can ask. So we might bring Beck back a little bit, and we're going to ask her a few things that she's noticing as well. Beck, Leslie has made the comment that you've had a polite introduction to one another. How are you? How are you? Andy said he was only just hanging in there. Did that land a little bit oddly, or did you realise that all health professionals are under pressure at the moment?
Yeah, well, I kind of got that, you know, being a nurse myself and knowing how stressful it can be when you're busy, and you know how stressful they must be now with COVID, that I just assumed he was just very busy.
Okay, so busy is one interpretation as opposed to full of virus, which is
no, I didn't kind of weird. That didn't enter my head, I suppose, because my head's not full of the virus at the moment. It's full of my situation. So yeah, I just thought they must be just really busy. Yeah.
Okay, and in negotiating how to ask a question and wave your hand, what did you notice before that made you stop and clarify that with Andy?
Oh, I just got, because it's something I automatically do, because like the only people I'm used to having a video thing with are my kids and the grandkids, and there's something we just always do, right? Wave at each other and we interrupt each other. We're a family. And when I did it, then I suddenly realised who I was doing it to, and I felt it was probably a bit rude, which is why I just wanted to clarify that it was okay. Yeah, and I also wanted, well, the reason I wanted to interrupt him because I was worried that I would forget what I was going to ask him if he kept going. So
it was raised that I didn't, even though I asked you, we invited you to have a summary or go straight into questions. I didn't invite you to ask questions within my answering your question, which say if there's anything that's unclear, just stop me at any time, which would have been good.
Yeah, so maybe that's another thing that we can think of in terms of our preamble to these conversations, as well as identifying how to interrupt. Even the word interrupt sounds a bit rude sometimes for those who are perhaps not as forthright as Beck. So maybe how to ask questions and stop me if I'm rambling on might be something that's good to identify at the outset. And in terms of emotional state, Andy, where do you think Beck's at?
She seems in a reasonably, she seems in a relatively good state. She's clearly had time to assimilate the diagnosis of progression. I know she's had radiotherapy to the spine, so a little bit of time, a couple of weeks have gone by there. She knows where things are at. She's had basic treatment options explained, so she knows she's got a number of options and that the trial's an additional option, and she really seems in a good space to really think, yeah, so do I want to do this trial or do I want to carry along the more conventional route at this stage? So she seems in a good space to have this conversation in a good space to really properly consider the trial and make her decision, or certainly to receive information which will enable her to make a decision down the track.
Mm-hmm. And I'm going to ask Leslie. Leslie's our consumer rep, Renee, who you just saw on the video, and she's there. Leslie, can you tell us, and we'll check it again with Beck just in the chat, what you've noticed about Beck's emotional state, please?
Thanks, Fran. I guess she feels unsure of what she needs to do. So I think I noticed that quite a lot of the conversation was quite technical still, even though we are talking about a clinical trial. But the need to, even though Beck's got a nursing background, which this conversation could quite possibly be somewhat different to someone who's not in the health industry, but the need to, I guess, really check on her personally. Like, I think it would be better if there was more of a conversation around her knowledge of what clinical trials are, perhaps before you jump straight into the clinical trial, and what is normally involved, using examples of something that, you know, a classic example at the moment would be the COVID clinical trials, you know, something so that she can actually sort of, I guess, assimilate with what is being asked of her if she was going to participate. But I think she's coming across to me that she's a little bit confused and unsure of what the next steps would be and that sort of thing.
Mm-hmm. Okay, so even if she's in a good place emotionally, there's still going to be a lot of uncertainty around this decision.
That's right.
Yeah.
That's right.
That's
and
okay.
I think that's where, you know, and I'm sure Andy will further down the track, the supportive measure of a clinical trial really comes into play here.
Yeah, it's a good point. We'll come back to that. Now, we're going to let Andy and his coughing spasms off the hook at this point for getting us rolling. And I'm going to ask a favour of David Porter. David, are you running this trial at your site?
I'm not sure. The short answer to that. We would like to. We certainly put our hat in the ring, and I think we've got it.
Okay. On the list there, Nicholas Zankowski, what about you? Oh, yes, David Porter is. Excellent news. All right, let's pop you up there, David, and we'll let Andy have a relax.
Much appreciated.
Thanks for going.
Okay, I'm feeling stitched up now. Yeah.
David, do you mind popping your video on?
Yes, so a number of New Zealand sites about which we are very pleased. You'll know it's something of a passion of mine. All right, David, let's help you get set up. Anything you've noticed about your setup there that you, now that you've listened to the first part of the conversation?
You're on mute, David.
So I missed what you were saying, Fran.
Sorry. Since you've listened to the first part of the conversation, is there anything you'd like to just adjust about your background or things you've noticed or would comment upon?
Well, yeah, if I'd known that I was going to be having a conversation, I certainly wouldn't be having it in here. And for preference, I'd rather like to have a haircut, which is an impossibility in our centre at the moment.
And mine too. Mine's tomorrow.
I'd also quite like to, I think it's very interesting the talk about, how we would set up, things with microphones and the setting of the earbuds, etc., to make it much more accessible. I think it's fair to say that we as a centre have done a lot more telephone conversations in telehealth. In fact, I don't think I've actually done a Zoom consultation more than once. So this is all very new to me.
Mm-hmm. And Renee, any comments that you might like to adjust about David that might help him there?
Oh, no, I think I'd like to acknowledge, David, you're obviously in your personal space. And so, other than going and kind of changing that completely, I suppose the only thing we would acknowledge is the glasses thing, which is just something that's so hard to resolve. And just flagging for you in your other environment, you probably have different lighting. But again, doing things like changing backdrops or just tilting the glasses if you can a little bit down or the screen a little bit sideways can help. But yeah, no, I appreciate that you weren't expecting to be there at 8 o'clock on a Thursday evening.
It's 10 o'clock here, so
10 o'clock, right? Yes.
Yeah, you're lucky I'm not in my pajamas.
Andy has said you look very academic. So.
Thank you, Andy.
Yeah,
okay.
So tilting your eyes down actually does make a little bit of a difference, and you could just push yourself back a tiny bit. Maybe it would help if the chair moves.
Okay, yeah, some room there.
Okay, it's a beautiful green wall.
Okay.
So we're going to bring Beck back again.
Yep.
And Beck, I think you've probably got lots more questions. So we've now got David chatting to you from Auckland, and I'll just bring him online now.
Okay.
There we go. And what would you like to ask next, Beck?
Well, one of my biggest concerns is the amount of time that is going to be involved if I do take part in this trial. The visits, because when I wrote them all down from watching that video, there was quite a lot of visits, more than I think with chemo or with just maybe having the injection. And I want to know where I would have to go for those visits if I have to go into Toowoomba, because, excuse me, I live in a property and it's, it can be almost a, over 3 hour round trip. So that is one of my questions. So maybe if we can start with that, because, yeah.
Well, that's certainly been how it has been up until now, that people have had to come and see us. But what we're trying to do with the study is to introduce the ability to do what we're currently doing at the moment, which is to consult with you at home, so that we can minimize the number of times that you have to come and consult with us. I think it is true that the studies do involve a lot more time commitment from you than just having standard treatment. And I think what I'd say to you is that the reason for that is that we're still trying to learn about these drugs, whether or not they're effective, whether or not they're safe. We're all gaining experience with them. So it is important that we do that in a structured and careful way, so that we're not endangering you in any way. And in that way, we get good data and are able to help other people later on know just exactly what we are achieving with this and what downsides there are to treatment. If we knew those answers already, we wouldn't need to do the experiment.
So you don't have any information, therefore, what if taking this drug is any more beneficial than just having the injection by itself?
That is the underlying thing that we're trying to prove with the study, but we've got good reasons for thinking that it will be important, an improvement. There's a lot of work that's been done up until now that has said this is a valuable study for us to be doing, because and justifies us doing the research that we're doing. So because we think that there is real hope that this will turn out to be a better approach than you could perhaps get from just having the injection by itself.
Okay, so can you, because I have to explain this to my husband.
Yes.
And my son, and my husband tends to work in, you know, okay, well, the chance of this versus the chance of this, he works in numbers, he's a numbers person. So if I had to explain to him, if I do this trial with everything it's going to involve, and I'm lucky to get the drug, for example, what's the probability that that's going to work better than if I just have the injection without being on the trial?
Okay, that's a tough question, because I think if we knew that in advance, you know, we would be able to say we don't need to do this study. But we know that people who have been through the treatments that you've had in the past have responded to upadacitinib in the past, and we're now at the point of trying to prove that that's a thing in a broader population. You know, so we're trying to introduce the drug earlier into the treatment phase, for example, and seeing if that gets better bite against the cancer than we have, you know, using it in the studies that we've done with it up until now. But we do know that it works in some women who have had that treatment, and we also know what some of the side effects are.
So women that have had that treatment, not on the trial, just had it for some other reason.
In earlier studies, you know, that have led into this one.
Okay. Oh, well, that's actually makes a bit more sense now. All right. So I guess the big question now is about these side effects.
Okay.
Because
So we might just pause there for a moment, if you don't mind. So David, what are you reading from her discussion about her husband and the sorts of questions that he might ask?
Yeah, so the impression that I got was that, you know, she wants to have, you know, the best and most modern and the best chance of, you know, getting better. And he is also expressing his concern about her health in that way, that he doesn't want her to be wasting her time doing something that might be detrimental to her. You know, just being side effects, being a guinea pig in a study, you know, that the investment of time is justified, and that it's not taking her away from the things that he would perhaps like her to be doing.
Okay, so can you think of some ways that we might be able to engage him in conversation about this? Because the question he's asking is it's the one the trial will come up with an answer to.
Yes.
But what ways might people suggest, and again, pop it into the chat, to engage that family member in the discussion and the decision making?
The obvious question is to ask if he is there and he would like to be part of the conversation, and if she would like him to be part of the conversation.
Okay, so inviting them in, or arranging scheduling ahead of time so that a family member can be there. If we can't do that, if he's out on the paddock somewhere, what other options does this give us that we might not have in real life?
Well, has he got his iPhone with him, and can we patch him into the conversation?
Yep, absolutely. Can we patch him in? That could work. And I suppose also, could we record this conversation or this video interaction, and then she could talk through it with him at a later time. So those are things that could be very important, if, as one would anticipate, the support of a family member is going to be important to the conversation. And Andy is giving you applause. Tough gig for having jumped in. Thank you very much. Anything that you've noticed about Beck's emotional state or processing from the conversation?
I'm guessing, if I'm being honest, I'm being sort of reacting in the way I think Andy is saying, you know, I'm sort of a bit overwhelmed by, you know, doing this at short notice without the prep and not without knowing, you know, perhaps say some of the side effects of hepatocertive as
Yes, and we won't go down that pathway tonight. Because
part of how I've been reacting is, I guess, panic to that. So I haven't been perhaps noticing everything that I would normally notice, I don't think.
Okay. And I'm going to ask Maria. We had a few comments before. Maria, was there any words or jargon Leslie might wish to comment, or any of you? I see that Yada's there. That any ways in which this trial was described that you felt might have had an impact, a startle or an adverse impact at all on Beck?
I think, yeah. Can you hear me?
Yes.
Oh, sorry. I think, yes, there's still a lot of uncertainty in her part, and you know, just being unsure and other things that are probably prioritizing around her, around social issues and family, that's contributing to, would be greatly contributory to her decision making. So I don't know if a little bit more time will be helpful for her.
Okay, so she's maybe processing. Andy's noticed experiment, which was something I noticed as well. Possibly wouldn't use that word in a clinical trial context. It is an experiment, and if someone was a scientist, they might understand very well the idea of controlling all aspects of the experiment as much as you possibly can, so that the only difference between the groups is the drug they're taking. But to people from the outside world, that may be something that's a little bit challenging, and being careful with our jargon, of course, is something that we're always having to catch ourselves with. Maria, do you work as a research nurse?
Yep, I do.
Great. Now we're going to make the suggestion, because we've got a little bit of time, that we let the oncologist off the hook and we bring you, Maria, in to have a chat, not so much about the detail of the trial, if you're not familiar with it, but a little bit more about her family situation, because I wouldn't...
Maria, are you able to turn your video on?
Yeah, just give me a sec. Sorry, in the kitchen.
No worries at all. Absolutely understand. And Beck, I'll get you to turn your camera on as well, please. Okay. Just wanted to check in with you, Beck, I suppose, in that part of the conversation. Was there anything that sort of stood out for you or that was interesting, or how did you feel that your question was answered?
I guess by the end of it, I got more of an understanding as to why the two drugs could be better than just the one drug by itself, by his explanation about people who already had that drug before, blah, blah, blah. But to be honest, I still feel a little bit like the trial is about, well, I know the trial is about collecting data, but I still feel like I'm not convinced that it's my best interest is at heart here. You know, I know they need people on the trial, and they need people who've already travelled the same journey that I've travelled with the treatments I've had, and they need this group of people. So I'm not, I know everybody means well, but I'm not so convinced that focus is on what's best for me rather than collecting the data for the future.
Yep. Was there anything from a video conferencing perspective that you noticed that was interesting or that you picked up on?
He's got a very busy office, which could be good. Lots of books. Maybe that means he knows what he's talking about. I don't know.
Fair enough. And just, I suppose I wanted to check in about the word experiment. So that word was used in the conversation. Did you notice?
To be honest, I at the time didn't bother me so much, but the word that's still sticking in my mind is so we can collect data. I think he said that. I don't know how many times he said it, but that's what's in my mind, is the collection of data rather than this is what's best for you.
Right. So it's not so much the word experiment for you. It was because we're doing this for this bigger picture. It was really not about you as an individual in this case. Yeah.
Yes, exactly.
Okay.
Yeah.
Thank you. Maria, do you have access to your camera and no kitchen at the same time at the moment?
Yes, I think I can now. How do I?
Just click on the little camera icon.
Oops. Switch it on. I'm in a little iPad, sorry.
That's okay. If not, Fran, did you want to do this as a phone call?
We could, although we have another, I know Mona's here, we have another study coordinator.
Okay.
Mona, would you feel comfortable possibly cooking up your 3-course challenge, or already starting to think about Saturday night's dinner?
So is Mona, sorry, is that M. Martin Smith?
That's me. Yes. Hi.
That's you, Mona. Hi, do you have your camera?
Oh my goodness. Yes, I do. But I'm just happily listening.
How about a phone call then?
Okay. Yeah. But okay. Who do I ring?
You ring Beck, but we'll get her to put her video on. Off you go. She's still got some questions.
Okay, so hang on. So let me just see how I can change my setting.
Your sound is quite clear.
Okay, so you can hear me. Hi, Beck.
Oh, hi. Hi.
I'm Mona. I work with Fran. I work with Fran Boyle in clinical trials.
Yeah. Hi, Mona. Nice to talk to you.
Good to talk to you. So, do you have some questions on the trial?
Yeah. I've had a conversation with the doctors, and I just really am still a bit unsure as to what is the benefit for me going on the trial. And yeah, because I'm weighing up a few things about, how to manage all this at home, and I want to make sure that I choose a trial because it's the best thing that's going to help me,
yes,
rather than just help people down the track.
Yeah, absolutely. That's totally understandable. That's totally understandable, and clinical trials have to be right for you and work for you.
Yeah.
And everything, so it is very important that you totally understand everything that you're going into, and you read all the details prior to saying yes. So whatever you entered them into, it's a voluntary. You completely enter it voluntary, and if you change your mind, it's all fine too.
Yeah. So okay, so I guess so I'm understanding that the drugs that I take, the drugs will still benefit me some way. Look, I suppose my big reluctance is just the time it's going to take. I've had treatment for the last 2 years, and we've tried to just move on from that. And I live on a farm out of town, and I'm going to have to go to all these extra appointments and have all these extra blood tests. And I just feel that if I'm going to do all that, then I want I don't know, I guess just more of a conversation about that's going to be worth it. I don't know.
Okay, and that's totally understandable. So what we can do for you is actually sit down and work out how many times and how you have to attend and how many hours it will take, and how we can minimize the impact for you.
Yeah.
Okay, so
I mean, yeah, because when I was my other chemo, I was able to go into like Warwick, which is only 20 minutes away compared to all the way into Toowoomba. So there's a way that I can manage to have some things closer.
yeah,
that would be better. And then I don't know, the other thing is, when do I have to start this? Because I've got a few things happening with the family and I want, yeah, by what I understand, you get diarrhea for a month and all that sort of stuff. And I want to be able to plan things, you know, so I don't know how soon they want me to start this. And if I delay it, what does that mean?
Okay, all very, very rational type questions. So we can work out, you know, when you've, you know, so because usually there's a washout period with clinical trials. So
I didn't understand.
Sorry, what often happens is that if you're starting a clinical trial, are you on treatment now?
No, I just had some radiotherapy. They've stopped the other treatments. Well, we're working out what to do next.
When did they stop the treatment?
Oh, but 3 weeks ago, when I had my scan and I was diagnosed with the metastases again.
Okay, so what we can do is make a check out when you have some. Is there some major family events happening?
My son is getting married.
Okay, so we can work around that. We will make sure that, you know, you are going to the wedding and we'll make sure that will happen, in the sense of we can work around that.
But I want to be going to the wedding well-ish.
Yeah.
I don't want to be running to the toilet with diarrhea and vomiting, and I don't want, you know, he's already postponed his wedding and I don't want him to postpone it again because of me.
Yes. There's plenty of options on managing the diarrhea. There's plenty of options there for you to manage that. When is the wedding?
It's early January, so it's still a few months away.
Okay, so by the time we get to January, we'll have worked out all the problems, or, you know, if there's any issues, we'll have worked them out.
So meaning I should start it before then?
When it is right for you.
So Mona, just hold it there if you don't mind, and thank you very much for jumping in. Everybody knows how successful our clinical trial unit at the Mater is, and now you know why. It's all about Mona. And thank you, Beck. You seemed, Beck, to be really taken aback by the idea of a washout, and you queried that. And I noticed that you raised your hand as well. But that's starting to look, which is highly trained, I think. Mona, thank you very much for doing that. So I think, unfortunately, we're out of time. We could go on, but the Kiwis have to go to sleep, and we're about to have another enormous electrical storm here in Sydney. So we may, in fact, go off the air completely. But what I'd like to do is just thank all of you who participated. I think what we can see is the teamwork aspect of being involved in these discussions, that trial coordinators and research nurses are going to pick up on different things sometimes to the oncologist, and that all makes for a really appropriate consent kind of quality assurance in the end. And again, if you are having 2 or 3 people in the conversation, there's actually nothing to stop you having your clinical trial coordinator on the screen. If they're not in the room with you, if they're working from home, you can have 3 people as part of that conversation as well. So that's something else to think about from a technical point of view. Next time we meet, David won't be in his broom cupboard, and we'll give him plenty of warning. But I do love the colour of your broom cupboard, David, and it is full of books, and you do look very academic. It's sort of almost Tolkien-esque. I'd like to also thank Andy for jumping in, and Leslie and Maria for their comments, and others as well. Thank you also to Renee, who's worked on a variety of clinical trial consent projects with us at BCT, and I think hopefully will make for better telehealth for all of you. The technical people who've been involved today have also given us some hot tips about use of Zoom if you are presenting at a conference, and some of them are not dissimilar to what you might wish to use in telehealth in terms of lighting and sound, etc. And I hope we might be able to share those with you. I think increasingly people are being asked to record their presentations for conferences ahead of time, and there are lots of things you can do to utilise the technology better. Thank you, Andy. Did you want to have any last comments?
Yeah, thanks. Yeah, that was very illuminating, and I think I guess what I learned, obviously, I am within my role, I offered, having not met the patient before, for her to go directly into questions, and I think in retrospect, if that occurred again, I would take them through the summary of the trial, and that might answer some of them in any case, and lay a sort of a backdrop to those more technical details. And yeah, David did very well. I spent about half an hour to 45 minutes learning about the related drugs and the phase 2 and you know, the PI3 kinase stuff, so I could answer that question about efficacy more straightforwardly. But so David did a very good job throwing in, and yes, thanks for being involved.
That's great. So Renee, any last comments?
No, I'm sure everybody wants to head off. I suppose want to say thank you guys so much. I hopefully you'll be able to focus on at least one little thing that might just make that difference, both for your comfort as well as for the patients. I hopefully you understand that, yeah, the outcomes work both ways, and maybe you guys might have a better time on a video conference as well. So thanks so much for your time.
Thanks, everybody, and thank you to our very kind tech support, Mitch, as well, and Annabelle, who helped to set things up for us, and Susie, who found the money. Good night, everybody.